Hello, good morning. Can you hear me? Good morning, everyone. Can you hear me? Egby Fever, Matthew Precious. Can you hear me? All right, thank you very much. Let's go to go. So, because of time, we are going to be rushing real fast. I remember explaining to us on Monday the different classes of cardiovascular drugs, and then I know we are done with the diuretics and the rest. If you have any question, please reach out to me personally in the either after class on Monday, or you drop it on you drop it with your class rep, and you send to me directly if you have my number on WhatsApp. This is a public video. I can't drop my number here. All right. So so we are going to start with alpha blockers. I remember teaching on talking about alpha blockers, and then telling you the whole idea of alpha 1 and alpha 2. I remember saying that alpha 2, they short the central. It just shuts the central nervous system. That's I try to give you a scenario where alpha 2, they shut the transformer in. If you are talking about NEPA lights now, alpha 2 goes to the transformer to short. Why alpha 1, we actually go to the particular house to cut the lights. You understand? So if you are trying to look for a particular action, you definitely want to go for alpha 1. Okay. So now let's look at a case study. Mr. Obi, 72 years old, with hypertension and benign prostate hyperplasia. All right. So hypertension and BPH, prostate. So this patient has hypertension and this patient has prostate. Now let's see. So was prescribed Digoxin 1 milligram at bedtime. Now I didn't say this in class because I told you in class that there is an advantage of case studies. When I see case studies, some information that were not mentioned, I'll mention them. So it is very important that if you like yourself, be part of those people that's going to listen, because my CA and everything are basically going to come from case studies. So it is better for yourself if you pay attention to the case study class and you listen as frequently as you can until you catch everything. So this patient that is having hypertension and prostate was prescribed Digoxin 1 milligram. Okay, what I was about to say is alpha blockers, alpha 1 blockers and alpha 2 agonists. What they do basically class, or how they are administered basically class, is that they are giving the lowest possible doses. You can see Digoxin here, 1 milligram, which is at variance to other class of drugs. So you are seeing 10 milligram, 20 milligram, 30 milligram. But you are seeing Digoxin here is having a 1 milligram concentration. So why is that? It's because of the side effects that come with these alpha 1 blockers. They are usually very massive. So they start at a lower dose and they continue thereafter, increasing the dose gradually. If you want to also stop the drugs, you also reduce it gradually. You don't stop it at once. All right, this class of drug alongside corticosteroids, that's how they work. You don't stop corticosteroids like that or abruptly. You stop it over a period of time. That's reduce the dose every day until eventually the patient no longer needs the drugs again. That's the same thing with all these alpha 1 blockers. So if you know any pregnant woman who is on any alpha blockers or alpha 2 agonists like metidopa, don't tell them not to stop the drugs at once, okay? Because it can lead to severe side effects or adverse effect during pregnancy. So Digoxin 1 milligram at bedtime. The nurse is providing first dose instruction. So question A, what is the unique mechanism of action of alpha 1 blockers? Question B, what is first dose syncope? Syncope means fainting. It's not the grammar you should be afraid. So you can change that word syncope there. What is first dose fainting? And why does it occur with alpha blockers? Then there is a stage 3 specific instruction that the nurse should give. I already mentioned some already as I was talking. Why is Digoxin beneficial for both hypertension and BPH? Okay, so that's those are the questions. So we're going to look at the answer. The first question says the unique mechanism of alpha 1 blocker. So class alpha 1 blockers definitely are going to block the effect of alpha 1, isn't it? So I told you that in the beginning of an any exam, you just write what does alpha 1 normally do. The blocking will be the opposite of what it does, isn't it? What does alpha 2 normally do? The blocking will be the opposite of what alpha 2 normally does. So the smooth muscles in the veins and arteries, usually they contract in the presence of adrenaline or no adrenaline, or epinephrine or no epinephrine. They are the same thing. Okay, so you know that. And you see, alpha 1 receptors causes this vasoconstriction. All right, and they are present in specific region necessary for what? Sympathetic nervous system. For example, if there's a lion, there's a tiger, there's a snake, you need to fight. All of these systems go into play to encouraging all those actions, fight or flight. All right, the vasoconstriction that you need in your part of your eyes, in the part of your hands, in the part of your legs to run, happens because of what? Alpha 1 receptors in the veins. So now, when you are now blocking alpha 1 receptor class, it means that you are going to not, you are going to cause, or you are going to prevent vasoconstriction from happening. So when vasoconstriction stops happening, what happens? The opposite of vasoconstriction, which is then what? Vasodilation. All right. So alpha 1 blockers, they block alpha receptors and prevent vasoconstriction from happening. All right. How is vasoconstriction happening? Vasoconstriction is happening as a result of the secretion of noradrenaline or no adrenaline. All right. So that's that for that. So what is first dose fencing? I didn't mention this in class, but I mentioned something related to this. Now, because of how alpha 1 blockers work, what happens is this. Because of how alpha 1 blockers work, sorry for that break, I think. What happens is this, is the fact that the drug goes to the arteries and veins and stop a lot of vasoconstriction. Now, when there's a lot of vasoconstriction, there's a lot of vasodilation. Because this is the first time you're taking this medication, the veins dilate and the arteries dilate so well that there's very, very reduced amount of blood in the heart to pump. And this causes what they call fainting symptoms. You understand? Dizziness and then fainting. So patients are told that before they take their first dose, they take it in the evening when they are ready to sleep. It will reduce the symptoms of fainting. If this patient takes it at work in the morning, the patient can drop down and faint. And depends on how the patient hits the head, can eventually from there pass across to the other side of the world. Okay, so first dose fainting is as a result of what they call orthostatic hypotension. I explained this, and it occurs between the first to 3 hours. All right, basically because of the rapid vasodilation. So after the first dose, the second dose, subsequent dose, the body now gets, oh, I'm used to this drug. It no longer dilates as usual. It now reduces dilation so that what? It will reduce that fainting effect that happened in the first dose. You understand? You know when something is shocking somebody, they just give you Coke, one bottle of Coke. You just finish it. When they give you the second one or the third bottle of Coke, you will no longer be as excited as the first bottle of Coke. I really hope that with these few examples, I've been able to explain what first dose fainting means. All right. So if I now say the 3 instruction that you give, nursing consideration, that you will give to people that are taking alpha 1 blockers. From that explanation of first dose fainting, you say take first dose at night when you want to sleep. All right. When you are going to, remember I also tell you that when you are going to the restroom, you get up slowly, isn't it? Don't just stand up from the bed straight. You sit down first for a few seconds. After sitting down, you stand up. Do you understand? Then because of the dizziness it causes, you avoid driving or operating machineries during the period of taking the medication. Then you also avoid alcohol, because alcohol will also cause that we worsen vasodilation, and then to increase the fainting or dizziness that comes. Then I also mentioned one at the beginning of this class. You start with the lowest possible dose, which is 1 milligram. Some patients are giving 0.5 milligram. All right, but mostly the standard dose is 1. All right. Then option D, yes, alpha 1 blockers have the benefits of addressing hypertension and addressing benign prostate hyperplasia, as BPH. So alpha-1 receptors are present in the bladder. I explained this in class. So do we act to reduce the size of the prostate, or reducing the vasoconstriction that's occurring there, expanding it. Also, the vasodilation that they cause in some other parts of the veins will therefore automatically reduce the blood pressure. You understand? If you go and use alpha-2 agonists, in the other hand, you are going to cause too much systemic reduction in vasoconstriction that can cause problem for the patient. And eventually, the patient is not going to have any effect on what? On prostate. Because alpha-1 is specific on prostate, you can use alpha-1 blockers. It will reduce the vasoconstriction in the prostate and also reduce what? The hypertension that this patient is suffering. All right. First dose, okay, Phoenix, see your question. Phoenix, can you please let me know your full name so I write it down? Does first dose syncope occur for everybody? Not necessarily. You know, I explained to you ADRO, that ADRO sometimes it occurs uniquely for some persons. So you can see a person, a good example is increased bradykinin that leads to cough, which is the use of ACEI inhibitors. ACEI inhibitors. All right. In ACEI inhibitors, when there is accumulation of bradykinin, it leads to cough. In some patients, I don't give you the percentage, about 10 to 20%. I think in my material I said 15%. All right. So that is it's not all the patient that will have this first dose syncope. However, you have to advise your patient to do what? To take it in sleeping position. Thank you very much, Noruwa Iwinosa Miracle. Then somebody is saying, sir, please, I lost you. That's Princess. Princess, please look for yourself. All right. So next case study that we're going to be working on is give me a few minutes, please. Case study 8, cardiac glycosides. So, Christas, please just type your question. Let me know if I can go back. All right. So this case study is on cardiac glycoside. Mrs. Kemi, 75 years old, with atrial fibrillation and heart failure, is on Digoxin, 0.25 milligram daily. She presents to the clinic complaining of nausea, vomiting, and seeing yellow-green halos around lights. Her heart rate is 48 beats per minute. Question A. What serious condition is Mrs. Kemi experiencing? List 3 classical signs and symptoms. Question B. Explain why hypokalemia increases the risk of this condition. Question C. What is the unique mechanism of action? Digoxin. What is the unique mechanism of action? Digoxin. Makes it have a narrow therapeutic index. Stage 2 critical assessment of the nurse must perform before every dose of digoxin. What is specific antidote for severe digoxin toxicity? Now, I think I mentioned in class that digoxin is one of the drugs that have a very narrow therapeutic index. Please, I didn't get the answer. I want to know how syncope happens due to the first dose. Krista, you are taking us back. Okay, Krista, first of all, before you come to morning case study class like this, ensure you wash your face and you are ready to listen. All right. Now, back to the point. The fact that these receptors have not been initially stimulated for alpha-1, that is the first dose syncope. All right. If they receive any alpha-1 blockers, they are going to absorb it. Absorption rate is fast, is rapid, and is very effective. So their stimulation can be what they call an exaggerated stimulation for the first dose. So that is the reason why Patients who are being started on alpha-1 blockers are told to take the first dose at night, so that when that exaggeration occurs, they will be in the supine position, that's in a lying position. Do you understand? So the second dose, they can now take the next dose subsequently, maybe in the afternoon, in the morning, or whatever. The syncope effect would have reduced. Not that it will not be there, but it will have reduced. Because why? Because the receptors are now what you used to these what alpha-1 blockers. So because of the drastic vasodilation, because of the drastic vasodilation, the blood levels leave the heart and they now expand in the vessels, causing the heart to beat very fast, palpitation, which is a compensatory method or mechanism in order to meet up for the volume of blood, and then leading to the fainting. And when the person faints, can injure or can sustain severe injury during that period. So in order to prevent all those processes, that's the reason why they say give the medications first at night. I really hope that helps you. Let me quickly go. So the first question we have for this Mrs. Kemi is, what serious condition is Mrs. Kemi experiencing? Now, class, the symptom that Mrs. Kemi is experiencing is known as what? Digoxin toxicity. Now, in digoxin toxicity class, is the accumulation of digoxin to a very, very dangerously high level that can lead to death. And one of the symptoms is vomiting, nausea. This patient is having a feeling of he doesn't want to eat, but they keep vomiting. He's having this nauseated feeling, but then there's lack of appetite to eat. That's really the first stage of digoxin toxicity. So what they do is that patients who have been started on digoxin, they're told to watch out for these signs. They're told to watch out for early signs of nausea, early signs of vomiting. All right. They're also told to watch out for. When they look at lights, they're told to watch out for all these yellowish or green things. Now, you know when somebody slaps you close to your white eye, all right, if there's a lot of pressure or power in the slap, it distorts. The way we see things is that we see light particles collide through obstacles and then it reflects in our vision. That's how we see things. The reason why you can't see in the dark is because usually there is nothing that is penetrating through those particles for us to see. After a while, when those particles become visible, I'm just trying to explain to you photochemistry or how we see. All right. Now, usually, when there is digoxin toxicity, okay, the eye becomes oversensitive. They now start seeing yellow, green halos. Visions are now blurred. Then a little bit of pain when they are looking at white light. So, as a nurse, when you are administering all these conditions, administering digoxin or cardiac glycosides, you tell the patient to watch out for these symptoms. When they watch out for these symptoms, then you can easily withdraw the drug, because why? They are already experiencing early signs of what? Digoxin toxicity. You understand? So, digoxin has already, this woman, Mrs. Kemi, she has already experienced nausea, vomiting, and she's experiencing visual disturbances. Now, I did not ask class, that's her blood pressure. Sorry, her heart rate. Her heart rate is 48 beats per minute, class. Her heart rate 48 beats per minute. Please, I want to know, is it around the normal or is too high? Who can respond? Is that 48 beats per minute too high, or is around normal or too low? Then while we're at it, waiting for comments on that, Christas, let me know if you are clear. If you're not clear, let me go over it again. Zion Adebayo, it is below the normal. Phoenix, it is too low. All right. Okay, Christas is clear. Okay, thank you so much. All right. So, who can tell me what is the normal range for heart rate if that is too low? Destiny Iyorogbe. All right, who can tell me normal heart rate, please? Where is Yusuf? I've not seen Yusuf this morning. Is Yusuf in this class? 60 to 100. God bless you. Faith, thank you very much. Hope you didn't use ChatGPT, you guys. If you are responding like this, really, and in real life you really know it, then you are ready for the exam. And no need for us for all these classes where I'm stressing you guys. But it's fine. Thank you very much. 60 to 100 is the normal range. Okay. Please, I'm looking for Yusuf. It is supposed to be evidently absent, and I need to know if Yusuf is not present in this class. So, 60 beats per minute, and this elderly woman is having 848, so it is below normal. It's below average rather. So what we are going to do is that she already have what they refer to as bradycardia. Bradycardia is part of the symptoms of Digoxin toxicity. Then there's confusion, there's fatigue, there's weakness. You understand? All right. Then the big question is explain why hypokalemia increases the risk of this condition. Now, class, when I was explaining mercury version of Digoxin, I told you that Digoxin blocks what? Sodium potassium pump. Okay, remember in class, sodium potassium pump, isn't it? Sodium potassium pump. Okay, remember. You can remember, just note it there. All right. Nobody can remember. I understand you students. That is how it is. But Digoxin blocks sodium potassium pump, and then when it blocks it, it leads to what? Accumulation of calcium, which then improves what? Contraction of the heart. Do you understand? To contracting pressure of the heart. Do you understand? Not necessarily palpitation. So that is that. And now, hypokalemia. When there is hypokalemia in the heart, or when there's generally hypokalemia, what it does is that it increases the chance of what? Digoxin toxicity. Do you understand? All right. So hypokalemia will definitely affect Digoxin toxicity. I think, did I give the potassium level of this patient? Yes, I gave potassium level of this patient. I also told you that if I'm giving you any level of anything in the exam, I will also give you the range. But fortunately for this particular question, I did not give the potassium normal level. I just take 3.5 milliequivalent per liter. All right. So, okay, thank you very much. All of you responded that I mentioned in class. So, the next question. All right. So, I should explain the mechanism of action and the narrow therapeutic index of Digoxin. What is the unique mechanism of action that makes it has a narrow therapeutic index? So Digoxin inhibits sodium potassium ATPase, all right? This evidently increases intracellular potassium, okay, that causes an increased contraction. Do you understand? And then there's a stronger contraction. All right. So when there's a stronger contraction, this will control the heart rate. All right, and then can definitely lead to what they call atrial fibrillation. All right, or sorry, can control heart rate that will also control atrial fibrillation. Now, the reason why there is a small therapeutic index in Digoxin is that usually the level between the active concentration that will cause a cure, and the concentration that is toxic, it's not usually very far. All right, so usually anything above 2 nanogram per milliliter, Digoxin is already toxic. However, from 0.5 to 2 is the effective range. But anything above 2, Digoxin is already toxic and can lead to death. So you see that if you as much as double the dose of Digoxin, you can actually lead to death of a patient. So what usually happens is this: Digoxin is now made in very, 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 very small doses. You understand? So as much as 0.25, 0.015, 0.2. You understand? So that for patients who need any smaller dose, they will have to break. For patients before patient can get to a toxic level, they will have to take at least 2 or 3, which is the rating is already wrong. So as a nurse, what you are going to advise when you are giving Digoxin, you tell them, on no account should you take more than 1 tablet. On no account should you take 2 tablets. On no account should you take 3 tablets, because all those once they take 3 tablets or 2 tablets, it has gotten to toxic level and they can die. Because why? It impacts contraction of the heart. So the heart contracts too heavily, it leads to heart attack and death. All right. Option D. What are the 2 things or 3 things you can tell the patient or check on the patient before you administer potassium, or say you administer digoxin? You check for the pulse and you check for potassium level. All right, check for the pulse and check for potassium level, because definitely the mechanism of action affects the potassium level. It's all right. So I think we are done for that question. Okay. Specific antidotes. That should be an assignment, class. Assignment, specific antidotes. Specific antidotes for digoxin toxicity. So now I can mention that I'm going to be giving you a lot of assignments. So I will let your class rep know the assignment I will give to you, but definitely you will not be submitting any assignment on Monday. You will not be submitting any assignment on Monday. I'll give you an assignment maybe after Monday class or during Monday class. So please note this down as your other assignment. Specific antidote for digoxin toxicity. All right, know it and know the doses that is used. Somebody's asking a question. Christas, so sir, digoxin is constantly abused to promote deaths. Somebody should look after this girl. All right. It's not abused to promote deaths. It's not used to promote deaths. Doctors have other things that they used to kill, not kill or provide euthanasia. Euthanasia, mercy killing. You want somebody's willing to die. And I've not seen any case of suicide or death where they use digoxin. I've not heard of any. It's not very known. Now you are knowing it now, Crystal's princess, and it's a problem. It's a problem that I'm teaching you something like this. But please ensure you do not use it for something negative. So, case study number 9, class 3 antiarrhythmic drug. Now, let me just give a summary of what antiarrhythmic drugs are. Antiarrhythmic drugs are drugs that control the electrical impulses of the heart. All right. So, basically, all the cardiac drugs that we have studied. All right. All the cardiac drugs that we have studied class, they fall under, they are used differently at different intervals and different times to do what? To address antiarrhythmic drugs. To address antiarrhythmic, or arrhythmias, cardiac arrhythmias. All right. So that is the idea behind all of these antiarrhythmic drugs. Now, because of time, I'm going to skip the antiarrhythmic drugs class. I will skip it because I want to go back to it when I really have to talk about them. Now, the reason why is because I've not taught you a particular class of drug where this amiodarone is. All right. When I'm done, I will come back to it. So please, class rep, just note it down. During our revision class, I will mention it in passing. All right. It's not much. It's just very short. So let's go to anti-angina. Okay, that's the next case study. So Mr. Ahmed, 66 years old, with stable angina, uses sublingual nitroglycerin, 0.4 milligram, PRON. PRON means to be applied when necessary. He also has a prescription for sildenafil, 50 milligram, from his urologist for erectile dysfunction. All right, sildenafil is a drug that increases blood flow to the penis to treat erectile dysfunction. So erection is basically blood flow to the penis. All right, and that helps. Sildenafil definitely. So if I want to ask you now, if you want to have an idea what class of drug sildenafil is, I believe somebody in this class should know already, because I've already explained to you some class of drug that increase blood flow to the veins and arteries. So it's not just that. It's not like I'm just giving an idea what sildenafil does. Okay, but it's not like they're in the same class. Also, it also means that people who are taking alpha 1 or alpha 2 should not be using sildenafil. There are going to be contraindications there, or there are going to be interactions there. Why is there going to be interaction, class? There's going to be interactions because one of them increased blood flow, or one of them increased blood flow to the erection, for erection. The other one increased blood flow to the veins and arteries. If you take the two of them together, there's going to be massive vasodilation and cardiac arrest. So you see all those stories where you hear people dying, old man dying on sex, dying. It's not supernatural. It's not like it's not juju. It is because of the fact that there is a massive vasodilation, and they are doing something that is what exacerbating. They are doing something like an exercise. So the palpitation is increasing. Heart is compensating. Heart is not seeing the blood. The blood is vasodilating an organ. It's causing erection. And this person is an alpha 1 blocker or alpha 2 agonist that already causes vasodilation. So there is massive loss of blood in what? In the cardiac muscle, in the heart. So heart is pumping too fast, and then shock, and the person dies. So now you should have an idea. So when you hear any news like that, or somebody dying because of or participating in any sex exercise and dies, you should be able to understand what's the idea behind it. You should not just, you don't need to know the drug before you have an idea. This patient must have been hypertensive, and this patient must have been on either doxazocin or metidopa, or you understand, correct? That's a smart student. So that's that for that. Let us go to the question now. What is the mechanism of action of nitrates in relieving angina pain? All right. Option B, what is the combination of nitroglycerin and sildenafil? Absolutely. Why is the combination absolutely contraindicated? 3 marks. What instruction should be given about proper storage of sublingual nitroglycerin? Why must the nitroglycerin patch be removed for 10 to 14 hours? What happens if worn continuously? Option C, the patient uses sublingual. If chest pain is not relieved after 3 doses, what should he do? So now, what is the mechanism of action of nitroglycerin? Basically, class, you see, anything that causes contraction or constriction or reduces pressure will always come with what? Pain. Because why? There's going to be excessive stimulation of the cells around it. When vessels constrict, or when there's vessel constriction, there is an associated pain. A good example: when the uterus contracts to remove all the content it has during menstrual flow, some patients will feel pain, or some women will feel pain, while some will not. Now, all of them will feel something, but not all of them will feel pain the same way. Why is that? Because of our individual sensitivity to pain. All right. Then when a woman is giving birth, the contraction that occurs in the womb or in the uterus will also lead to pain. I don't know if you understand. So when you're hearing vasoconstriction, there are many things you should be hearing. You should be hearing increased blood pressure. You should be hearing increased sensitivity. You should be hearing amount of blood flow present is plenty. You should be hearing pain. So when you're not hearing angina, which is a pain in the cardiac cells, all right, then you should know that most of the drugs that are going to be used to manage that condition will either be causing vasodilation for relaxation, you understand, or will be reducing blood flow to that area for reduced sensitivity. In the case of nitric oxide will increase smooth muscles relaxation. So when there's smooth muscle relaxation, there is artery dilation, that is the arteries are wider, improve blood flow, all right, and then oxygen demand is reduced. Okay, now sildenafil on the other hand will also cause vasodilation. All right, now sildenafil will cause vasodilation. Nitric oxide will also cause vasodilation. Now, class, pay attention. Sildenafil causes vasodilation by breaking down what they call cyclic GMP. I will explain this on the board. All right, this will be about among the class I will do alongside Amil Daron then. Okay. Now, because my next class is not coming tomorrow, on Monday, I'm going straight to reproduction. I'm leaving from cardiovascular pharmacologist. So that's why I'm just explaining this here. So sildenafil causes vasodilation by breaking down cyclic GMP. All right. Nitric oxide causes vasodilation by increasing cyclic GMP. Now, when I draw this thing on the board, you'll be able to see why one will increase and vasodilation will occur. Why one will break down and vasodilation will occur. You understand? Now, but picture this: one is increasing and one is breaking down. So there's already what a counterproductivity in that place. Okay. Then at the end, what is the end result? There is also what a massive vasodilatory effect. Exactly why I told you why people who are taking sildenafil cannot take alpha 1 blockers and alpha 2 agonists. There will be so much vasodilation and blood pressure can drop too low and can lead to stroke, death, myocardial infarction, or whatever, or cardiovascular collapse. All right. So if a patient wants to take sildenafil, let's say this patient is having erectile dysfunction, of course, you cannot take away the sexual needs of a man. If he wants to take sildenafil, you will tell him to do what? To stop his nitric oxide for a day. So you just say, oh, you want to have sex with your wife or your other half. You just stop this for a day. Take sildenafil the next day. And when you're done working, you can skip that next day again. Then start your nitric oxide the other day. But what's there? Can you not stay away from sex? Because angina is a very serious issue. The pain from angina can actually lead to cardiac arrest. All right. So proper storage of sublingual nitric oxide. All right. Nitric oxide is highly reactive to lights. Lights, not NEPA light. So nitric oxide is usually reactive to light, and when it stays in a bright place, what happens is that it deactivates the active ingredient there. All right, and then it can now become toxic. So what you do is that you store it in a dark bottle. So somebody says, sir, why do we need this information? You will need it for your OBJ. All right, because all these are little things you need to know. Okay. Then you do not transfer it to another bottle. Don't say, oh, this bottle is dirty, let me transfer my nitric oxide tablets to another one. No, because that bottle that is made for it is the bottle that will actually protect it from light. By the way, you can still keep it in a dark place. That's what's in the house. Like you put it under the shelf, you put it in your wardrobe, you put it inside a locker in the kitchen. Oh, no, not kitchen, sorry, kitchen is hot. Except you have a very good ventilating system. You put it inside a locker, you put it inside a drawer, you put it in the car closet. So stuff like that, the place that has lock to reduce the light around the environment. Okay, you cannot put it on top of the shelf, can't put it on top of the fridge, can't put it inside the fridge, can't put it on top of the table or on top of the television. So those are the things that you give your patient when you're advising them. You understand? So you keep away from heat, keep away from light, keep away from moisture. Okay, then your nitric oxide after every 3 months, even if they are remaining, you remove it. You discard it and buy a new one. Because usually, as you're opening it and taking new doses, light is entering to the bottles and affecting the other ones that you have not taken. So after 3 months of using your nitric oxide daily, you replace it, whether they are remaining or not, you discard. So I've actually seen some patients come and they buy a new bottle. You understand? Usually the bottle comes in amber color. Amber is black, like a little bit dark. All right. Then there's cortisol on top. If you open some medications, you see like that. All those medications you see that there's cortisol inside is basically to prevent light. So when you're administering them, don't just open them and start gisting. You do what? Open, collect, and cover back. You understand? All right. That's for that. Then how to know if tablet of nitric oxide is still okay? When you take nitric oxide, it has a specific sensation. It has a tingling sensation, something like fire is under your tongue when you put it under your tongue. All right. If you put it under your tongue and you don't feel that fire sign, you know that you have not taken nitric oxide. Or it has expired or light has deactivated the nitric oxide. You understand? So that's for that. Then when you are using nitric oxide generally class, there's a period known as the nitrate free period. So usually around a particular time of the day, if you are using the patch, there's a patch, you understand, because of these complications around the tablets, lights, because some people can be careless. So they now have a patch, all right, so you can apply. And then because of that, because you are using a patch that is constantly applied to the blood from the patch, you do what? You remove it for some period of time, usually 10 to 14 hours daily. You understand? Because why do you remove it? So your body does not get used to nitric oxide. If it gets to nitric oxide, vasodilation effect will no longer be present. Remember receptor sensitivity, all right? I think I taught you receptor sensitivity, what leads to dependence and tolerance. You understand? Tolerance, when the patient is tolerant to drug, it means the receptors no longer are stimulating as they used to. You understand? So you need more dose to be able to get the same effect. You understand? So please remember that I taught you that class. So it happens with nitric oxide. So if you just use the patch consistently, but if you remove the patch for 12 hours every day, you should be able to have some necessary effects. All right, that's that for that. Any questions so far? Any questions? Let me take questions. Let me take questions. I'm waiting for your questions, class. No questions. If you have no questions, if I don't get any questions in the next 2 minutes. Okay. Okay, I've seen question. Adebayo Zion, maybe network is slow, something like that. Is nitroglycerin the same as nitric oxide? No, nitroglycerin is a formulation of how the tablet is formulated. How you understand? But it is converted to nitric oxide in the body. Okay, for it to work. You understand? So nitroglycerin is how, for example, I taught you pro-drug, isn't it? Where a drug is taken and then converted before it starts acting, that is exactly what happens. So nitroglycerin is converted to nitric oxide and then works. Now there's nitric oxide as it is. Okay, there's nitric oxide as it is. People take it like that, they abuse it. Okay. Then nitroglycerin is a tablet for cardiac issues, for erectile dysfunction, for vasodilation, and the rest. So nitroglycerin is a drug. You will see it as nitroglycerin. When you say you want to buy nitroglycerin, they will give it to you in the pharmacy, of course, with prescription. You understand? So any other question? Then people who abuse nitric oxide, they usually put it in because it comes with some effect. People who abuse nitric oxide, they use it to put in balloon, they abuse it, they do a lot of stuff with it. That is the gas that is formed when nitroglycerin is taken. The reason why people who take it do not have those same effects is because of the dose. The dose that is being consumed, the nitric oxide dose that is being consumed by those that abuse it in parties, in balloons, you understand? Is people who are using the balloons, people who are using the parties. You know, those parties you go to now, you see them with balloons. All those balloons, they're basically are nitric oxide inside, right? And it causes so many symptoms, all right, because of the dose we are taking. But patients who are taking nitroglycerin, the reason why they will not feel that effect is because of the dose they are taking. Do you understand? They're quite very small and minimal. All right, somebody is Omo Igboji. Sir, is angina not the pain that arrives from the death of cardiac cells? Yes, angina is the pain that arrives from the death of cardiac cells. And I said can lead to cardiac glycosis, can lead to cardiac arrest. All right. So I've been asking for Yusuf. Nobody has been able to provide me Yusuf. Why? Nobody has been able to provide me Yusuf. Yusuf, who else again am I supposed to? Okay, I've seen class rep message. Then Blessed, which is your stand class rep. Blessed online. Is it Blessed online? Let me see. Okay, class. I have been here, sir. Sadiq Yusuf. Oh, he's active. Who is Egbe Favor? What is that? I thought balloons contain hallucin. There are many chemicals that are abused. Do you understand, Christas? There are many chemicals that are abused. All right. Okay. Hallucination is hallucin is probably, I don't think there's a gas known as hallucin. What they refer to is something that makes people hallucinate. Not because that is part of them, and some other things that are there. I don't really know. I don't care. All right. All right. So thank you very much, everyone. Class, I will stop here today, and I appreciate your time. I really do. What I'm going to do for us is that I took attendance while I was lecturing. You notice I was quite distracted because I was trying to check everybody that were coming in. Now, I know that some of you, your names are not the name that I see here. I'll get the names. I'll get the names of those. Some of you that bear funny names. So what our advice is that next time when you're coming to class, you just let your name be your name. Like Krista Society now, that's not your name. Okay, Princess is the name I know you as. Then Sadiq Yusuf is Claire. Then the other lady I told, she wrote her full name, so I got it. All right. Because the reason why I had to do that as Phoenix, I got your name. The reason I had to do that is because I realized that the questionnaire I sent, the link I sent, some persons would just send the link to the class, and then I started getting names of people because the software I use for this live is able to pick people's name as they are joining, and then it helps me know those that are around. So when I started comparing the names of those that are filling the Google form and those that actually came for the class, I started seeing discrepancies in the names. Okay, so that's the reason why I actually decided to take attendance myself, and that's the reason for the small delay that you see me have while I was talking. So I'm done. I'll stop here. If you have any question again, please relate it to your class rep. If you don't have my number directly, or you relate it on the comment section here, I'll get a notification when you drop it. I'll reply you as I can, as soon as I can. Then on Monday, we'll move straight to other part of the class. Now, please, class, another thing you have to pay attention to is the fact that um, um, your CA is going to come from case studies. So please note that, and your CA is theory, it's not going to be OBJ. So note that those of you that are attending class, I don't expect you to have any problem. And I've mentioned that some of the information that I drop here are going to be very, very necessary in your objective. So like those informations of nitric oxide, or sorry, nitroglycerin, I keep using the two of them interchangeably. Okay. Sir Okoji, Jolanda. Jolanda is my street. Tell Jolanda to come and knock in my gate that she does not have a phone. How would Jolanda say she doesn't have a phone? Are you in Jolanda's house right now? Jolanda should be in the house. I know her house. So Moses Mercy, that you're making excuse for Jolanda, I know her house. I don't know if you are saying Jolanda is with you, you have to show me proof because I know Jolanda's house, close to my house here. So that is that for that. So that's the point. I will come to class on Monday. We'll talk on reproduction. If you have any question, please send me any question on cardiovascular. Let me deal with it before Monday. Monday, I'll just deal with reproduction, and then we'll continue from there. Thank you very much. Our phone is very, very bad. So you're adding very bad. It's all right. It's fine. Yolanda, you see me, okay? Whenever you see me, just let me know. If you see me and I'm driving past, just wave and let me see how you were able to meet Moses Mercy. Explain to me personally why you were able to meet Moses Mercy and you are still in your house, except you are not at home. Okay, sir, you can come and see. So Moses Mercy is in Jolanda's house. All right, no problem. We're all here as proof. When I drive out this morning, I will see if I can see the Moses Mercy there. Thank you very much and see you on Monday. God bless you.